I'm going to just pull up here the disclaimer slide in case somebody wants to read it for a couple seconds. I personally have no disclosures to mention. But yeah, thanks everybody for joining us for our webinar. Like Megan said, I'm Dr. Vasquez. I'm the Assistant Medical Director at ProHealth One, and today's webinar is going to be on pressure injury prevention. So the objectives of this webinar are going to be to talk about the human, financial, and organizational consequences of pressure injuries on patients, healthcare systems, and overall quality of care. We're also going to discuss evidence-based strategies for developing, implementing, and sustaining a comprehensive prevention program, obviously tailored to institutional needs. We're going to recognize risk factors that contribute to the development of pressure injuries, and we're going to describe methods that we can use to assess and prioritize the care for vulnerable populations, such as those critically ill, immobile, or the geriatric population. And we're also going to talk about clinical practice that you can implement in your facility to reduce the incidence of pressure injury and promote the optimal patient outcomes. So pressure injuries are very expensive. In 2006, in the US, we spent about $11 billion on hospital stays in which a pressure injury was either the primary or secondary diagnosis. On an individual patient cost, one pressure injury can range from about $3,500 to about $60,000. So obviously, in order to mitigate these costs to patients, hospital, and society in general, it's crucial that we develop pressure injury prevention programs. In the United States, between 2000 and 2012, the average pressure injury cost per year was about $11.6 billion, and the individual cost per patient was between $500 and $152,000. Pressure injuries, preventing pressure injuries costs less than actually treating the pressure injuries. Some estimates say that the cost of treatment is about 2.5 times more than the cost of preventing pressure injuries. So it's very crucial that we try to prevent these at all costs. There's also other impacts in addition to costs for pressure injuries. They are a common recurring problem throughout the world's healthcare system and are often preventable. They reduce the quality of life. They lead to higher costs, as I mentioned, longer hospital stays and more readmissions. They significantly increase morbidity and mortality. There's a burden associated with chronic wounds, such as pain, discomfort, anxiety, depression, and stress. And there's also social consequences, reducing social functioning, spiritual well-being, security, and autonomy. So most pressure injuries are avoidable, but not all. The definition of avoidable pressure injury is a pressure injury that developed when the provider did not do one or more of the following. They didn't evaluate the patient's clinical conditions and risk factors. They didn't implement interventions that were consistent with the resident's or the patient's goals or needs, and they didn't recognize the standards of practice. They also didn't monitor and evaluate the impact of interventions that those will put in place. That's why we round every week so that we can monitor and evaluate whatever new interventions we're using. And when there were any changes or no improvements or new wounds developing, we didn't revise any treatments that as appropriate. Unavoidable pressure injuries. So skin does not fill in its own. An unavoidable pressure injury is basically the opposite of an avoidable pressure injury. It's a pressure injury that's going to occur despite you're implementing what I mentioned previously. So you're evaluating the patient's needs, the clinical conditions and risk factors. You're implementing your interventions, such as air mattresses and such, and you're individualizing these needs to each patient, and you're utilizing gold standards of care for preventing pressure injuries. So these are wounds that occur despite the provider doing all these things. And these can occur despite the provider monitoring, evaluating the impact of preventing interventions, and we're revising these approaches as appropriate. Elderly patients with multiple comorbidities, critically ill patients with multiple organ dysfunction, and especially those with sepsis are at very high risk for developing unavoidable pressure injuries. So, risk factors. Most guidelines for preventing pressure injuries are relevant to all individuals, um, but there are specific populations that require specific needs due to their age, care setting, or clinical condition. Some of these categories and risk factors are listed in this table. So general risk factors can be limited mobility and activity, increased risk for shearing and friction, such as in morbidly obese, advanced age. As we know, our skin loses collagen as we age. Patients with moisture on their skin, so microclimates, especially like quadriplegic patients that tend to might have dysregulation of their autonomic nervous system, so they sweat a lot, especially in their back, so that creates excessive moisture and a microclimate that's um, prone to developing pressure injuries. There's also clinical risk factors, such as a past medical history of pressure injuries, issues with circulation, perfusion, diabetes, heart failure, malnutrition. There's also correlations with lab markers, so low albumin, high CRP, which is a marker of infection, low hemoglobin, so anemia. Um, and there's also mental past medical history, so like dementia, and your general health status. Population specific, so those critically ill, like in the ICU or CCU, um, neonates, premature babies, and when you're transiting to and from the hospital, as in the stretcher, that's a moment where you could be at risk for developing pressure injuries. Um, Patients in long-term care, rehab facilities, assisted living, in the operating room table, especially obese patients, palliative care patients, and such. Environmental risk factors can be such as in the operating room table, so the duration of operation, the longer the surgery, the more likely the patient is to develop pressure injuries. And then immobilization before after surgery or with the use of a cast. Like I mentioned, ICU stay, patients on mechanical ventilation, vasopressors with vasoconstrict the blood vessels. Other risk factors can be increase in body temperature, sensory perception impairment, and such. So, our first question. So, question number one, how confident are you in your facility's overall pressure injury prevention program? A, very confident. I believe our program is effective and consistent. B, somewhat confident. I think we do well, but there's room for improvement. C, not very confident. I feel our program needs significant improvement. Unsure. I'm not familiar with the details of our program. So we'll give you guys about 10 seconds to answer. Okay. All right. So these are the results. So the vast majority, so 18 out of 19 respondents said between very confident, some confident, and one not very confident. Okay, so let's go over some of those things. So a good pressure injury prevention program should contain the following elements. So it should be a multidisciplinary team that's including the MD, the doctor, the nurse practitioner, the RN, the LPN, the CNAs, the physical therapists, the dietitians, occupational, everybody. And everybody in that team should have a defined role based on their training and their experience. In addition, one should constantly be identifying any barriers and trying to minimize those barriers, such as having the right supplies, wound care products, prophylactic products, and prevention equipment, air mattresses, um, wheelchair cushions, etc. We should continuously conduct risk and risk and skin assessments for pressure injury development. There should be ongoing staff training, and we should consistently be educating not only the patients and the family, but each other. So the doctor should be educating the nurses, the doctors, so on and so forth. This should be a very collaborative and communicative um, process, and that would be those would be the elements for an ideal pressure injury prevention program. So strategies for building prevention into ongoing processes. So universal procedures will be applying skin assessments and prevention steps to all patients. We want to have routine communication, so we're going to discuss the risk status during team handoff. We're going to ensure that we set up the nurses or the staff for success by ensuring that we make these dressings easily available. In addition to preventative devices we might need. And we can also use visual reminders, such as cues. Here on the left, we have a turning clock that I find it's very useful when we use it. We can use logos, and these can prompt staff to reposition when it's due. So, and a pressure injury prevention program should include these six features. So risk assessment, support surfaces, moisture and incontinence control, turning and repositioning, reduction in friction and shear, and nutrition. And these are things that we talk about every week when we round. So the first element would be the risk assessment. So it's different. The frequency of when you're going to do these risk assessments is different depending on the setting you are. So in the acute care in the hospital setting, you're going to do it on admission and you're going to reassess about every 24 to 48 hours after admission and whenever there's a change in clinical condition. And that's really important. Some ICUs do them every shift, and general surgery recommends daily assessments. In the long-term care setting, it's going to be on admission, weekly for the first 4 weeks after admission, and then quarterly, unless there's any change in condition. And studies have shown that 80% of pressure injuries develop within the first 2 weeks after admission, and 96% of pressure injuries develop within the first 3 weeks after admission in the post-acute care setting. In home care setting, we're usually going to do those during our initial visit and reassess after every nurse visit. So the full risk assessment, we're going to screen the patient for the risk of developing pressure injuries. You can use different tools, so the Norton or Braden. We usually recommend the Braden. It's more specific and sensitive than the Norton. And then basically, if you do your assessment with one of these tools and the patient's flagged as high risk, then you're going to perform a full assessment. If the patient's not flagged as high risk, you're just going to routinely monitor for any changes. You're also going to try to identify modifiable and non-modifiable risk factors in these residents. And you're going to repeat these screenings if the health status changes or if the clinical condition changes or if the patient's more at risk. And then you're going to monitor these residents at frequent intervals based on your care setting, like I mentioned in the previous slide. Okay, so this is an example of one of the tools we can use to risk stratify our patients for the risk of developing pressure injuries. The Braden scale, it predicts the risk of developing a hospital or facility-acquired pressure injury. The scores are based on risk factors for pressure injury development. There are 6 risk factor categories. So sensory perception at the top, moisture, activity, mobility, nutrition, friction, and shear. And I would recommend that everybody be very familiar with the scale because we basically use it all the time. So for sensory perception, a patient with a 4, so the higher the number, the better, or the less risk. So a patient with a 4 has no impairment, response to verbal command. Everybody in this meeting is a 4 right now, for the most part. And a 1 would be a patient that is complete limit. So somebody that's essentially obtunded, unresponsive. So imagine a patient in the ICU with a vent on a vent and sedated, or a patient who is transitioning in the long-term care setting and is not responding to any painful stimulus or any command. For moisture, on the far right, we're going to have patient that's rarely moist, Skin's usually dry, doesn't really require linen changes, only sometimes. On the left side, so a more high-risk patient in the moisture category would be somebody that's consistently moist. Every time you go in the room, they're moist. They require, um, linen changes multiple times a day. As for activity, a patient that walks would be a four, would score a four. Um, and they do that at least twice a day, and they can at least walk inside the room once every 2 hours. And a patient that would score a one in this category would have best bed fast or patient confined to the bed. In terms of mobility, which is different than activity, would be a patient that would score a four would be a patient that doesn't have any limitations. They can essentially reposition themselves in the chair and the bed without any assistance. And a patient that would score a one would be a patient that's completely immobile. So you can be confined to the bed, but still have somewhat mobility. Or you could be a patient that, is confined to the bed, but is completely immobile. So, and that would be two completely different patients with um, different risk at developing pressure injuries. With regards to nutrition, a patient with excellent nutrition eats most of every meal, never refuses a meal. A patient with poor nutrition would score a one, never eats a complete meal, eats less than half of any food offer, or is NPO for more than 5 days. Um, and then with regards to friction and shear, a patient that would score a three doesn't have any problem, and a patient that would score a one would be somebody that moves feebly or requires some assistance. So with regards to those six categories, so five of those categories you could score a four, and then the sixth category only goes up to a three. So the max score would be a 23. Anybody with a greater than or equal 18 is at little to no risk, and patients with nine or less, a score of nine or less, are at extreme risk. So low risk patients, so those that score between a 15 and an 18, they have a 50 to 60% chance of developing a stage one pressure injury. Moderate risk patients, so those that score between a 13 or 14, have a 65 to 90% chance of developing a stage one or stage two pressure injury. And high risk patients, so anybody that scores less than a 12, have a 90 to 100% chance of developing a stage two or greater pressure injury. All right. Second question. So question number two, how confident are you in accurately completing a Braden scale assessment and applying appropriate interventions based on the score? A, very confident I can complete the Braden scale accurately and select matching interventions. B, somewhat confident. I usually complete it correctly, but sometimes unsure about interventions. C, not confident. I struggle with completing the scale or matching interventions. Or D, I'm not familiar with the Braden scale. So we'll give you guys about 10 seconds to answer the question. So out of the 17 respondents, 14 said very confident. So 16 out of 17 are between very confident, somewhat confident, and one is not familiar with the Braden scale. So with regards to support surfaces, which is another important thing that we should consider in our pressure injury prevention program, there are three categories essentially for pressure relieving support surfaces, group one, group two, and group three. So group one are going to be your static support surfaces. So they can be either air, foam, water, or gel mattresses. Think like a foam top, like a Tempur-Pedic. And some of the more newer ones have a combination of gel and foam. And then most of them have some type of waterproof covering in the healthcare setting, obviously, to help reduce shearing and friction. With regards to group two, these are going to be dynamic. These are going to be what we usually call our air mattresses, quote unquote. And then the bigger categories are going to be your alternating pressure mattresses or APM. They have weight shifting features and they have cells in different zones that are going to inflate and deflate with air. And these cells must be more than 10 centimeters for proper distribution. And these are going to essentially relieve pressure points in the resident that's laying on the mattress. Low air loss mattress, these are going to alternate. They have little air tubes inside that inflate and deflate. And basically, they change the microclimate like between the patient and the mattress. And these are usually the settings are usually based on the patient's height and weight, but you should obviously follow the manufacturer's guideline with regards to weight um, and the settings. And then there's the continuous lateral rotation mattress, which automatically rotate the bed um, to reposition the patient continuously. There's a risk for shearing, and usually these are used for patients with pulmonary therapy needs. Um, in the facilities, I usually round that. You will see a lot of these mattresses that, these quote unquote air mattresses that are a combination of both alternating pressure mattress and low air loss mattresses. In fact, the vast majority of the air mattresses that we use are going to be a group two and are usually a combination of these two categories. Group three, so these are your air fluidizing mattresses. They they have a circulation of filtered air through the silicone beads, and if you feel them, it feels like it's water, but it's really just thousands of little silicone beads. They can be turned off for reposition or for CPR. These are used for very high risk patients, patients with multiple stage threes or fours, patients with extensive burns, so very high risk for developing more pressure injuries, and patients after flaps. They're very expensive. They run 15, 20, $30,000. These group two are usually more in the couple hundred to couple $1,000. Um, but yeah, that's obviously a constraint for using these air fluidizing mattresses. All right. So general guidelines. Support surfaces do not prevent or heal pressure injuries on their own. I would say they're an aid, but selecting the right support surface does play a significant role in a pressure injury comprehensive care plan, in order to prevent and also treat pressure injuries. So they're an aid, not essentially a set it and forget it. So we have to match the support surface to each patient's unique risk factors and needs. Especially in the long-term care setting, patients have the right to refuse, but we should make sure that we always document not just the appropriateness of the support surfaces, but any refusals or any contraindications, such as a patient with a high fall risk, and any other alternatives that we've attempted. And we should always, always, always follow manufacturer's instructions for their use. So how are we going to check for bottoming out? Um, we're gonna, this is essentially done to evaluate the inflation and the effectiveness of the mattress overlay. So the hand check, so you can slide your hand with the palm up between the mattress overlay and the patient's sacrum. If you feel the sacrum or less than an inch of inflated surface, the patient is bottoming out. Basically, the patient's not being offloaded. Um, Obviously, this method does not work for all devices. And again, you should check your manufacturer's recommendations if you're unsure if this is an effective method to check for bottoming out with the mattress in your facility. Um, as for support surfaces for existing pressure injuries, if essentially the rule of thumb is if you develop a pressure injury while using a support surface, unless there's a change in condition, the support surface is not adequate. So you should always consider especially support surface if multiple pressure injuries on training surfaces wound worsen despite proper care, patients that are very high risk for new injuries, patients cannot be repositioned after pressure injuries, obviously after a flap or a skin graft surgery. Um, Patient's discomfort, patient can't tolerate the air mattress or the offloading regimen you have scheduled for the resident, or if the patient's bottoming out. So we'll consider a specially pressure redistribution seat cushion for high-risk individuals in a chair, wheelchair, or patients that are in the chair or wheelchair for prolonged periods of time, and those that are unable to perform pressure relieving maneuvers while in the chair. Obese patients should use a bariatric pressure redistribution seat cushion, and and again, these cushions should be based on individual patient's need. Ideally, we should have pressure mapping, but that can be very expensive and difficult to obtain at times. Patient's body habitus, posture deformities, so any kyphotic deformities, mobility, and patient lifestyle. So considerations when selecting a seating support surface or wheelchair cushion, we want to use loose, stretchable, breathable cushion covers that conform to the body. We want to avoid tight, non-stretch covers as it negatively impacts the cushion's performance. We want to select cushions and cover that promote airflow reduce trapping moisture and heat. This can increase the tissue temperature on the patient's bottom, raising pressure injury risk. We should inspect cushions daily per the manufacturer's guideline. We should involve in this on a multidisciplinary care team, physical therapy and OT, to assist the resident, to assist the team in selecting the proper cushion, and how to properly place it. And we should obviously always educate the patients, the caregivers on seating support surfaces use and how to maintain them. So with regards to moisture and incontinence control, another feature of our pressure injury prevention program is going to be to manage the microclimates. Um, in doing this, we're going to control the underlying cause of the extreme temperature of the skin or moisture of the skin. So simple interventions that can be used to cool the body temperature, reducing the number of linens and blankets, avoid the use of plastic mattress coverings, frequent reposition, encourage wearing cotton or breathable materials, having fans, and air conditioning ideally, but sometimes that's not available. With regards to moisture on the skin, skin moisture increases pressure injury risk. If you imagine when you were younger and you would go to the pool or the lake and you would have those macerated white wrinkly fingers that you could just easily peel away the upper layers of your epidermis. So the same thing can happen on elderly patients' bottom um, when they're essentially covered in moisture for the majority of the day. So we're going to assess the urine and stool for incontinence because that will cause obviously skin moisture, increasing the risk of breakdown. We're going to ideally try to use low friction fabrics like silk to reduce friction and shear, absorb sweat, and decrease heat insulation. And we're going to avoid heating devices. So heating pads, hot water bottles, bed warmers, as they can raise the skin temperature, not only cause burns, but they can also cause sweating and increases the risk for developing pressure injuries. Um, Here on the left, the do's and don'ts of cleaning the skin. Do treat the skin well by keeping it clean, dry, and moisturized. Do wash the skin area gently with mild soap and water, and use moisture barrier to protect the area from body fluids. Do clean with salt water, saline rinses to remove loose dead tissue. Don't rub or massage pressure injury or any hot spot, quote unquote, of the red skin. The skin's red because it's inflamed, it's damaged, and rubbing it will not improve circulation and might even cause more damage. Don't use hydrogen peroxide or iodine cleaners as they can change the pH and cause damage to the skin. And don't pat dry using a soft fabric. Uh, we should individualize the frequency of cleaning for every resident, as overcleaning can cause dryness and that can crack the skin and lead to pressure injuries and sores. Um, we should consider using non-rinse cleansers that maintain the pH balance of the skin rather than an alkaline cleanser. The pH of the skin is a little more acidic, around 5.5. So neutral pH would be 7. So normal skin pH is around 5.5. So just bear that in mind. With regards to incontinence management, we need to develop an individualized incontinence or continence management plan for each resident and their caregivers for toileting programs, changing incontinence pads, and regular skincare. We should clean and dry skin after each incontinence episode promptly. Excessive moisture will alter the microclimate and the pH balance of the skin. And this can result in denuded skin, erosion, erythema, inflammation, as the picture shows. With regards to incontinence products, we're going to use barrier products to keep moisture away from the skin. Silicone-based ointments can aid in wicking away moisture from the skin, and then zinc-based creams can aid in prevention and treatment of skin breakdown. You see a lot of products that combine both of these, and I always tell the nurses when I'm rounding that we should look at the back of the bottle because you're usually going to see the concentration of zinc oxide. Um, and for those that are very, very incontinent patients that, that are very incontinent, the higher the zinc concentration, the more protection you're gonna have on the skin. Those can come up to 40%. But again, if sometimes if you use high concentration of zinc, it can cause over drying, cracking of the skin. So as we mentioned, it should be individualized and you should reassess every week. So incontinence products that you can use for patients with incontinence are bladder catheters, indwelling or external, briefs, rectal pouches or rectal tubes. Those aren't used as much in the long-term care setting, but in the hospital, you can use those. You can use bowel or bladder incontinence programs, and you can use also high absorbency incontinence pads. So open systems, these refer to when an absorbent pad is placed underneath the patient to wick away moisture. So in this case, we're not going to use briefs or underwear. We're going to just place this absorbent pad under the patient. This alternative solution can prevent the patient from lying on a wet absorbent pad if changed and cleaned frequently. Um, we're going to moisturize the skin. It's suggested that moisturizing the skin to promote skin hydration can aid in preventing skin tears and dry skin. Moisturizing the skin routinely. You can use occlusive moisturizers. These prevent the loss of moisture or humectants. These draw water from the environment and enhance absorption. Um, so for repositioning and reducing friction and shear, mentioned earlier about turning frequency. So turning and repositioning, and I say this a lot during rounds, especially with patients with pressure injury, it's the most important prevention measure that preventative and treatment measure that we can do on preventing pressure injuries and for treating them um, in order to decrease the mechanical loads on the tissue. So some older research suggests that older patients, they should be turned every 2 to 3 hours. And studies showed that they had fewer pressure injuries. More recent research suggests that depending on the support surface used, less frequent turning may be optimal to prevent pressure injury. Um, Me personally, if they have a good quality group two air mattress, a combination air alternating pressure mattress and low air loss, I recommend anywhere between 4 and 6 hours turning, but that's obviously I individualize it on depending on the patient. So some patients may need closer to 3 or 4, some patients may be closer to 6. Um, and this is one of the examples of a turn clock that we can put in the patient's room. So draw sheets, we want to utilize draw sheets. We should keep folded draw sheet underneath the patient where they're sitting. This will make repositioning a lot easier. If the patient is on an air mattress, please remove the draw sheet after repositioning. When it's time to reposition the patient, simply hold the draw sheet, preferably with the help of another person, and slightly shift their weight. The rule of 30 for positioning in the bed. So we should follow the rule of 30, which indicates that we should elevate the head of bed no more than 30 degrees and position the body at a 30-degree lateral incline. Tilt the hips and shoulders 30 degrees from supine, using pillows and wedges to avoid pressure on hips and buttocks. We should alternate positions. So right, back, and repeat. So that's the turning clock. And we should avoid 90-degree turns to prevent excessive trochanteric pressure. So essentially, it's just a slight offloading. 30 degrees is sufficient to prevent pressure injuries. The head of the bed. So you can see this patient here in the Fowler's position. So you should keep the head flat or below 30 degrees. If for a medical reason you need to go above, you can use a semi-Fowler's position. You should support the patient with pillows under the arms and flex knees to prevent sliding. Um, you should consider seating alternatives. Sitting on the side of the bed is preferred for eating if a pressure injury exists. And You should position the patient to prevent slouching. Uh, Heel positioning. So float the heels. I say this every day during rounds. Um, we should elevate the heels using wedges, foam, or pillows to relieve pressure without hyperextension. Pillow placements. So ideally between the knees, if the patient's sideline or under the legs, mid calf to angles when supine. And if we're using pillows, we should, instead of just placing the flat pillow, I find it more effective if you fold the pillow, and that kind of creates a more rigid, or it doesn't kind of flatten out as quickly as just a flat pillow. These are best for alert, cooperative patients and for short-term use. This may be inadequate for agitated, demented, or highly mobile individuals, or those with stage 3 or greater pressure injuries. Some tips for heel positionings. Knees should be ideally flexed at 5 to 10 degrees to reduce the risk for developing a deep vein thrombosis. Heels should be off the mattress, um, and avoiding high pressure areas such as the Achilles tendon, and pressure should be distributed along the calf. You can use a positioning block if the foot falls into lateral or external rotation. You should follow manufacturer's instructions for heel suspension devices and remove heel suspension devices at least twice daily to assess the skin and perfusion, and remove them more frequently if edema or fluid shifting occurs. And I see this all the time with foam prevention boots that patients can develop. If they're not properly fitted, not properly used, and we're not checking them consistently, they can develop lateral ankle, lateral foot pressure injuries. Seating interventions. So extended chair sitting increases the risk of pressure injury. Limit the out of bed chair sitting. Consider psychosocial needs. Studies showed that fewer pressure injuries occurred with less than or equal to 2 hours of chair sitting, and we should individualize sitting duration based on skin and wrist assessment. Seated positions must minimize pressure, provide support, maintain stability, allow activity, and be patient acceptable. So weight shifting, we're going to incorporate dynamic weight shifts into care plans, considering skin response, pressure mapping, functional ability, and lifestyle. We're going to tilt the wheelchair 30 degrees before reclining to relieve pressure on the ischium and prevent friction and shear. We're going to avoid fully erect sitting to prevent pressure on the ischium. Choose appropriate seat to floor size chair wheelchair. And we're going to ensure that the feet rest directly on the ground or use adjusted footrest for a slightly forward pelvic tilt. Pressure relief maneuvers. So we're going to teach and encourage pressure relieving maneuvers for individuals seating for extended periods. This can be a 1 to 2 minute micro shift every 15 minutes for full capillary refill and tissue perfusion. I personally say, yes, you can be in the chair for 2 consecutive hours. But yes, you should ideally every 15 to 20 minutes reposition yourself so that the so that you reduce the risk of developing a pressure injury. So you can do this by leaning forward, sidewards. You can lift your arms, and intermittent standing for those patients that can stand with assistance and with assisted devices. So with regards to wheelchairs, without a cushion, patients are often unaware of the hammock effect. So where the seat sling dips, and then it increases not only pressure to your ischium and your spine, but also to your trochanters, kind of more on the lateral sides of your hips. Um, so you're going to watch out for discoloration of the skin. People with pale skin tend to get red patches. People with darker skin tend to get purple or blue patches. Um, so discard patches don't turn white when pressed. A patch of skin that feels warm, spongy, or hard, and we're going to watch out for pain or itchiness in the affected area. Other considerations for sitting intervention, you're going to consult a seating specialist, so physical therapy, occupational therapy for individuals who sit for prolonged periods of time. You're going to limit sitting to 60 minutes or less 3 times daily. Um, you're going to modify sitting schedules and cushions if pressure injuries don't improve or worsen. And you're going to balance bed rest benefits with psychosocial, emotional, and lifestyle needs. And you're going to individualize care plans and interventions to meet your patient's needs. Okay, for positioning devices, The five pillar rule. We're going to use the five pillar rule to reduce pressure at high risk areas. So, first pillow is going to go under the left to elevate the heels. Pillow number two is going to go between the ankles. Pillow number three is going to go between the knees. Pillow number four is going to go behind the back. And pillow number five is going to go underneath the head. So, pressure relieving devices. So, we're going to avoid the use of ring and donut shaped cushions. Because this tends to reduce the blood flow to tissues and can actually cause venous congestion in the tissues. Um, for with regards to medical grade sheepskin, evidence shows that this does help prevent pressure injuries. You should choose sheepskin that meets Australian standards for quality. Monitor for excess worms and skin moisture. This may not be suitable for everyone as it is animal derived. Question number three. So question number three, how confident are you in selecting and using a pressure relieving, or offloading devices and knowing when to change them out? A, very confident. I understand which devices to use and when to replace them. B, somewhat confident. I know the basics, but could use more guidance. C, not confident. I'm unclear how to select or change devices. And D, unsure. I'm not involved in device selection or management. So out of the 21 respondents, 20 were very confident or somewhat confident, and one was unsure. Okay. All right. Nutrition interventions. So with so you should always have a comprehensive nutritional assessment, and this should ideally be done by a dietitian. And will include food history, adequacy of nutritional intake, BMI and weight history, biochemical assessment and data, tests and procedures, physical examination focused on nutritional status such as muscle wasting, edema, deficiencies, and grip strength. Um, you're going to refer to a registered dietitian slash nutritionist if malnutrition is identified. There's a normal nutritional labs, low albumin, low total protein, prealbumin. The individual's at risk for or has pressure injuries, and if there's a change in condition. So other nutritional considerations, you're going to frequently monitor and evaluate nutritional status, weekly weighing. You're going to optimize protein and energy intake. You're going to encourage a high calorie, high protein fortified foods, supplements in addition to regular diet. For patients with stage 2 pressure injuries or higher, offer high calorie, high protein, arginine, zinc, and antioxidants with oral or enteral supplementation. You're going to assess the risk benefit of enteral parenteral feeding. You're going to ensure adequate fluid intake and encourage hydration. And for neonates and children, you're going to consider fortified foods, enteral slash parenteral nutrition support, or age appropriate supplementation. Prophylactic dressings. So, prophylactic dressings are applied to intact skin to prevent pressure injuries, especially over bony areas. You want to start these dressings early for high-risk individuals when possible. Evidence show that these dressings significantly reduce pressure injury incidents. You're going to use them with other preventative measure, offloading, reposition, and the prophylactic dressings. Um, considerations before using a prophylactic dressing, skin vulnerability and benefits, easy application and removal, microclimate management, especially with fluid contact devices, regular skin assessment, dressing thickness under clothes and devices, individual preference and comfort, cost savings, coefficient of friction, dressing size and design, medical device type and purpose, if applicable. So with regards to prophylactic dressings, you want to avoid excessive layering underneath medical devices to prevent increased pressure. Prophylactic dressings must not compromise device functionality. You're going to replace soiled, loose, dislodged, or excessively moist dressings. Daily skin assessments under dressing is crucial for effectiveness. So this might not be feasible in all healthcare settings. And then tubular bandages can secure prophylactic dressings when not to use prophylactic dressing. So patients with frequent fecal or urinary incontinence can soil the dressing, leading to prolonged skin contact with urine/feces. You're going to use barrier creams and ointments, preferably in those cases. Individuals capable of independent repositioning ambulation with no sensory deficits don't really need prophylactic dressings. And morbidly obese patients may prophylactic dressings may hinder their morbid obesity may hinder the correct placement of these prophylactic dressings due to the body shape and skin folds. And you never want to place prophylactic dressings under grounding pads. Education for treatment and prevention. So pressure injury education program. These are a list of topics that you should include if you're gonna do to include a healthcare professional pressure injury education program. So a lot of these we've touched based on. So risk factors, etiology and staging, differential diagnosis and classification, risk assessments, skin care and skin assessments, nutrition, selection and use of support surfaces, dressing selection for wound care, training and repositioning, including the use of equipment, documentation, and you're going to use an interdisciplinary approach. And that's our webinar. The next webinars are going to be the next one's going to be on December the 3rd, and it's going to be the topic's going to be managing lymphedema, and then the following will be on February the 4th, 2026, and it's going to be with regards to peripheral artery disease. If you have any questions, this is our contact information. Please remember we have our outpatient clinic down in Littleton, where patients can receive TCCs, VHTs. We have the moleculites. We also provide ostomy care and education. That's the contact information. You can also ask any of the providers running your facility for more information, or you can reach out via email, call us. And yeah, if you're interested in we have a new wound prevention program. So if you're interested in signing up for that, yeah, please reach out or ask one of the providers at your facility. These are our references. If anybody has any questions, I'm happy to answer.
Thank you, Dr. Vasquez. This is Lauren.
Hey,
So
Lauren.
just a reminder, if you have any questions, feel free to throw them into the chat or the Q&A. I do have a few questions already. The first question for you, Dr. Vasquez, is what are your go-to interventions that you automatically implement when you identify a patient that's either moderate or high risk?
It depends on the setting. There's no like one size fits all. It depends on the clinical setting, on the patient and risk factors. So I can't really just give you one answer. I got to look at all the risk factors. How old is this patient? Are they morbidly obese? Are they malnourished? Is it a 90-year-old male patient that smoked all his life, weighs 90 pounds, has diabetes, heart failure, is completely incontinent, and has Alzheimer's dementia, versus somebody that's um, a different resident. We can basically, it's going to be a combination of all the things that I mentioned during the lecture. So I can't really give you just the one answer, unfortunately. That's essentially why we round every week, so we can kind of gather all this clinical information, risk factors, and come up with a treatment plan. And sometimes we have to modify these plans as we go because there's certain things that we might not capture the first week during rounds, but maybe the second week or the third week. And then a lot of the work that we do every week, kind of like detective work, we got to figure out why something might not be working. Ask the CNAs, they're in the rooms more than this is mostly in the post-acute setting, long-term care SNF. Definitely ask the CNAs because they know a lot. They're in there more than I am, more than some of the nurses are, to gather the right information to come up with the treatment plan. Yes, air mattresses, so a combination of APMs, lower air loss. Those are great, but not all patients might need them. It might be a cost that the facility can avoid, um, and a patient might be a fall risk. But maybe let's put the mattress at the bottom of the floor, put a cushion next to the floor, next to the bed. So there's not a like a one size fits all type of answer, unfortunately.
No problem. Thank you. Another question from an attendee. What is your thought about blood-filled blisters? Is it always pressure related?
No, that's also kind of one of those things that's on a you can develop blood-filled blisters with infection. So certain bacteria can cause blood-filled blisters to appear in the but if we're talking about right bedridden patient on the heel, non-ambulatory, right, same example, 90-year-old male, 90 pounds, bony prominence, blood-filled blister. Yes, the most likely diagnosis is that, but one of the things I mentioned is the differential diagnosis. So today, I always have, three or four things. This is the most likely diagnosis. And yeah, today it might be pressure injury, but maybe in 3 weeks we realize that it was something else. So the short answer is in the long-term care and skilled setting, most likely than not over a bony prominence in a patient with limited mobility, advanced stage, and malnutrition, yeah, probably. But there's other things that can cause blood fibrillars.
Wonderful. Okay. Another question that's come through. How do you address skin damage, or how do you address skin damage from moisture versus pressure, and how do you tell the difference between the two?
So, so moisture associated skin damage is kind of like an all-encompassing term, and it can be from sweat. So in the summer, I see especially in lower research facilities that I go to, may not have central air. There's usually a sharp increase in incidence of just MASD, and not just necessarily in all patients. Some patients that are not completely incontinent just from the heat. And there's also a diagnosis of heat rash called malaria. And I see that sometimes patients sitting on a plastic mattress cover, a hot room, and it has a particular appearance that if you're rounding with me, I can show you some pictures. But essentially, yes, for moisture-associated skin damage in incontinence patients, so there's incontinence-associated dermatitis, and the patient has to be incontinent for that diagnosis. And those are usually going to be, to try to give a more succinct answer, you're going to have a more diffuse and irregular edges, and it's going to look more like a rash. Yeah, you can have some blistering and denuding because the urine and the feces can irritate the skin to a significant degree. And then if you add shearing on top of that, you can have some blistering and it's not a pressure injury. However, pressure injuries for the most part, you are going to see a more symmetrically shaped ulcer. Obviously, stage one is just a red area, but it's obviously, again, like taking the whole clinical picture into consideration. Um, you can have, and this is maybe what the question is trying to, or the attendees trying to ask is, yes, you can have moisture-associated skin damage. Patient was incontinent, but now something's changed, and now not only do they have now the skin's at risk, and now something happened that now they're going to develop a pressure injury. And then you can go back and say, this is not a moisture-associated skin damage anymore. We've addressed that. We put a Foley catheter in place or an external incontinence management device in place. So it's not so much the incontinence now. Sweating's not an issue, but now maybe they had a stroke and now they're more immobile. So now they're developing more of a pressure injury. As for other things you can use, so not just symmetry and regularity of the affected area, but tissue quality. You can't have it's if there's eschar or slough, it's a pressure injury by and large. There's other things that can cause you to have an ulcer with pressure with slough and eschar, gangrene for arterial insufficiency, burns, so on and so forth. But in this setting, bedridden patient. If you see slough or eschar, you're you're more likely looking at a pressure injury.
Perfect. I think that's all the time we have as far as questions go, unless there's some last minute questions that come in. But if Dr. Vasquez, you could switch the slide deck over to our contact page so that anyone can write down our email or phone number if they do not have it. And thank you all for attending, and please feel free to reach out to us if you have any additional questions.